It is so lovely to see you all. Before I go further, I would just like to remind us that we are, of course, meeting on the traditional territories of the Coast and Strait Salish people. I've been a visitor to these lands for 25 years, and they have been an absolutely spectacular 25 years. This is just a great place to live, and to meet, and to work, and to play. And so I'm getting the signal here, louder. Okay, thank you. This is exactly what we need. So just a couple of things before we begin the program. First of all, you all have name tags, and I hope that if you haven't picked up one, that you'll find it on a table just outside the door. Number two, we are, of course, we've got a chock-a-block program for you today, which is fantastic. This is a lovely problem for us to have, let me tell you. But what it means is that we're going to be really time challenged. And so, in fact, in true conference format, we're going to give you the hook when the time is up. We'll give you a warning, and you'll be seeing people with time cards and so forth. So part of the reason for meeting here, of course, is to continue the skills development, to give you an opportunity to speak in a conference setting to colleagues about the work that you're doing. And part of that is being mindful of the time that's allocated. It's also partly about just a respectfulness of the fact that lots of people are also wanting to share their ideas and have their opportunities. And so if we fall off the timeline, then we're shortchanging others who have worked just as hard as you have to create a powerful presentation. So I'm just, okay, that's kind of where we're going to start from, if that's okay. And we are also going to ask that at the beginning of each session, that the speakers for that session just occupy these seats over here, because that way everybody will be proximate to the stage, and we won't have to worry about spending time waiting for people to come from the very back and meander through and so forth. One last thing is that in order to, again, maximize the time that we have available, is we will, time permitting, entertain questions while the next presentation is being set up. Okay, so we have tried to build in a little bit of transition time, so we don't want you 10 minutes next. What we would like is just to use a couple of minutes, if the time permits, to engage with questions, but know that while that's happening, the next presentation is going to be prepared. Okay? So that's just how we're going to run things, and I hope that's going to be okay for everybody. And I would encourage you all, because you can tell I've got nervous energy too about this. Just take a nice deep breath. You're among friends, you're in a very supportive environment, and your peers and colleagues are really eager to hear what you have to say, just as you all know that you're eager to share your experience with your colleagues. Now, before I introduce our keynote speaker, I really do need to just share this with you. This is today's Globe and Mail. No, I didn't bring this in because Rob Ford is on video smoking crack again. I actually, I mean, as interesting, sad, and funny as that is, perhaps, or just sad, I brought it in for the story that's on page 2. And I don't expect you to be able to see this, and it's not a very interesting picture anyway. But it's the text that's important. It is a moment in time, and that time is 40 years ago today, May the 1st, 1974. I was on the eve of my 19th birthday, and I'm turning 25 later in the month. So the text reads this. Health Minister Marc Lalonde tabled a green paper calling for a dramatic shift in health policy thinking, an emphasis on prevention of illness to mitigate soaring medical costs. Titled A New Perspective on the Health of Canadians, the document influenced policymaking around the world, but was greeted in Ottawa largely with mocking indifference. Tory Heath McCrory dismissed it as, quote, solidly in the motherhood realm, and joked that everyone knows it is better to be slim than fat. That same spring, parliamentary debate was dominated by legislation, also tabled by Lalonde, to ensure the Canadian Football League's monopoly over pro football in Canada. The CFL is still alive and kicking, but most of the recommendations in the public health report remain unfulfilled. 40 years ago today. How appropriate is that? So I think you've heard me say public health is a marathon, not a sprint. And I think what we're going to hear today are stories that engage in that marathon. The first one we're going to hear from is our keynote speaker, Dr. Astrid Brouselle. Astrid is an associate professor at the University of Sherbrooke. She is also a CRC chair in health evaluation, and she's going to speak today about the importance of listening to community voices in doing evaluations. Astrid, please. Would you please welcome Astrid?
Great. Yeah. Hello, everybody. So I've heard that you are all finishing your program today, so it's a kind of party today. And thank you, Michael, for inviting me to join that party. And I understand that the idea is that you will be presenting your work, important things you've done this year. And I took the invitation with the same idea, so I decided I will try to show you my work, part of my work, and try to see. I was thinking, what would be an important message? What would be an important thing I'd like to give you, and for you to begin in your life? So I took the message quite as an exercise, and today I will present you some project, and it's my great pleasure today to come and talk on the importance of giving users a voice in program evaluation. Evaluation. How many of you know about evaluation? Well, those who do not raise their hands, you're laughing, that's good. But those who do not raise their hand are liars, I suppose, because you all evaluate in our day-to-day life, okay? And evaluating is on giving a judgment on something, on an intervention, which can be a policy, a program, a drug, a practices. And we are evaluating in our everyday life, okay? We are determining the worth and value of things. But what makes the exercise in research a bit different is that we try to use a systematic inquiry process, okay? And in the field of evaluation, we have different approaches, different models to have a valid judgment or to have a valid judgment on interventions. And we conduct evaluation with different purposes, from improvement of the intervention, social betterment, accountability, social agenda and action. But in these approaches, in this model, what is the place given to users? Well, if we scan the literature in evaluation, we have different models and approaches, and these models and approaches are different according to their core foundational values or core foundational principles on which they were built, they were thought, okay? So you have different paradigms and different approaches. And I will just take few examples, but if you take naturalistic inquiry, okay, people will try to understand how people experience, how they interpret, how they see what's going on around them, okay? And what is the place given to users in this model? It is the same as for all participants, okay? You can have collaborative and participative approaches, okay? But it can be with stakeholders, and it will not always be with program users or intervention users, okay? You can invite different stakeholders. They all participate to the evaluation and you will have a judgment on your intervention, but will there be a place for program users, intervention users? Not always, okay? And on the other hand, you can have also an instrumental use of users, okay? When the evaluator wants to, or the researcher wants to get particular information, and it will solicit participants with the idea of getting that type of information, okay? If you want, for example, to know participant satisfaction, okay, you can make an inquiry and test and see, are your users more satisfied or not? Are they satisfied with the services or not? Okay, but that's a kind of instrumental use of participants' views. So, in evaluation, we put a judgment, but it's not automatic. It's not general that you will include participants' views or users' views in all evaluation. Okay, you have to decide to do that. But is it so important? I will try to show you, and this is the aim today, I will show you different examples on how including users' views into your evaluation can change the view, your interpretation of the program. Okay? So this is what we are going to do today. So I will use three examples. Three examples of programs I conducted or evaluations I conducted, I'd rather say. And I will show you what were the results without including users' views, and what are the results when you include users' views into the program, okay? And you will see the impact it can have on the intervention, on your evaluation results, or on policy, right? If you don't understand something, you raise your hand, okay? It will be my fault. It will be my... Okay. So, evaluation 1, the UNAIDS initiative for access to antiretroviral drugs in Chile, okay? Just a few words of context. It's like a time machine. We are going back in the time, okay? The first cases, AIDS cases, were diagnosed in 1984. How old were you, Michael, at that time? 13. Okay. And this research took place in 1999, okay? So it was at the time where drugs for AIDS began to exist, and in particular the tree therapy, which was with a great effectiveness on patient health, okay? But it was also the time where these drugs were really expensive because there were patents on them. So the tree therapy cost several hundreds to several $1,000s a month, okay? So the UNAIDS decided to conduct an experimental initiative in 4 different countries where the aim was to negotiate with pharmaceutical companies to lower prices and at the same time to work with governments to make drugs available in a good manner in the country. So that was the objective of the program. What was my role? Well, I was in charge of the evaluation, the implementation evaluation analysis in Chile. So it was one of the countries that participated in the initiative. And with the implementation analysis, the objective was to identify barriers and facilitators that impeded or facilitated the implementation of the good implementation of the initiative in Chile. First, a few data. I can't talk about all the results, sure, but I will show you some spotlights, okay? So you see that in 1998, the government, without the UNAIDS initiative, was able to offer 700 B therapies, okay? B therapies, 2 drugs, for this amount of money, okay? 1 year later, with the UNAIDS initiative, they were able to offer 750 B therapies and 750 tree therapies. Okay, so they were able to introduce the most effective therapies in the country. So they doubled the number of B therapy and they added the same amount of tree therapies. You see here the coverage, needs coverage, okay, it's decreasing. Okay, it was 100% in 93 and it was 40% in 99. You know why? It's a tricky question. Huh? Well, it's because needs were increasing, okay? You want more needs. So if you were able to offer more drugs, you were not able to cover all the needs, okay? And you see that they were able to offer B therapies and 3 therapies for almost the same amount of money. So if you look at program effectiveness, the NIH initiative effectiveness, you can say, well, that's effective. Okay, it works. The objective was to offer a huge amount of therapy, and they succeed to offer more therapy for the same amount of money. So that's success. So let's go into the program and see what's working in that program. So that was the program, the NIH initiative, as it was conceived, and it was supposed to be implemented the same way in 4 different countries. We won't go through details, okay? You take a picture with your eyes, then you close your eyes, and then we pass it, and that was the program implemented, okay? So we won't go again into details, but what happens is that you see that the program, okay, close your eyes again, I will go back. Okay, that was a program that was supposed to be implemented, and that was the program that was implemented, which was completely different from what was planned. So when you think about effectiveness, okay, what was effective? Was it the NIH initiative, or was it this program that was implemented in Chile? Okay? Okay, close your eyes again. Shoop. Hey, I don't have the same picture on my computer. Carmel, where are you? No? You don't? You see gray? Do you see gray? Yeah, a bit gray, okay, right. Do you see gray? No, huh? Well, you have gray zones here, 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 here on the computer, okay, which do not appear. They do not appear on your screen, but you have lots of gray zones, okay, and the gray zones indicate the difficulties in implementing the program. And you see that we had a program that was planned, that was not implemented as planned, and in its implementation, they faced huge difficulties. So what was the effectiveness in that program? Where is the effectiveness? Okay, is it in the program implemented, or is it in what really happened? Okay, but so what we've learned from this implementation analysis, we've learned that there was a program plan. It was planned it was implemented in a different way, and they experienced huge difficulties in implementation, and I won't do the list, okay? So that was without users' views, okay? We conducted around 50 interviews, in-depth interviews with people that participated to the implementation and its initiative. But I also conducted observations, you know, in the clinics. I met patients, I went to patient associations, I went to local patient associations, and I met people, you know. And what I've learned with that? Well, I've learned, among other things, that there was a huge informal market going on with antiretroviral drugs in Chile, okay? And so I began to study this informal market, okay? And there were various forms, okay? And what happened is that you had people who had AIDS and who had no hope of getting a therapy, who decided to go abroad and decided to go to Argentina, to go to Mexico, or even to go to Spain, because the flight ticket was lower than buying the drugs in their country. And they decided to be as a Spanish or as an Argentine, and, you know, benefit from the public coverage, okay, public health insurance. You had other guys who decided to go where they had contacts with doctors and try to import drugs in Chile and sell drugs to other patients and finance their therapy with selling to others. But you had also international solidarity. If a patient was dying in Switzerland, okay, people just gathered the drugs, you know, because these drugs could save others' lives, okay? So when someone was dying, the first thing they were doing was gathering the drugs and sending it to Chile or other countries, okay? But you had also an informal market at the national level. And how did it occur? Well, that was the conjunction of various factors. First, you had the coexistence of private and public healthcare systems. Those who had work, were employed, were insured for the health coverage by private insurers. And with this private insurance, they were not insured for catastrophic diseases, so they were not insured for AIDS. So they had to pay for their drugs. So they had to spend several $100s or $1,000 for drugs. But they had no access, free access to drugs. Those who were in the public system were covered for catastrophic diseases. So they were able to receive free drugs for the AIDS, HIV/AIDS, okay? So you had people, so you had this system. Second element, social stigma. I will go back, close your eyes, I don't want to hurt you. Okay. I put here a picture. You see that people are covering their face, okay? What they were doing, it was in 1997, 2 years before the project, okay? You know, you had a huge social stigma in Chile when you had AIDS. You were losing your job, you were losing your apartment, you were losing your friends, and you were living in huge poverty. So you had people living in huge poverty, benefiting from a public health insurance with free drugs, but they couldn't afford a living. And on their side, they had people employed with a private insurance system ready to buy for drugs, okay? So that was a system, you know, it was not so difficult. In final, people were selling their drugs. Hey, I've got the 3 therapy. I'm able to sell it for $700 a month, and I'm able to afford a living with that. Well, they were dying several weeks or several months later, but, you know, they couldn't do another way. And this is social stigma. People were really hiding because they were having AIDS and they were fearing that stigma. And just an anecdote, when I met patients, I asked them the first question, can you tell me who you are in a few words? And they were all telling me, you know, if I ask you that, you will say, I am Astrid Brouselle, I work here, and you know, you put in different important things that are in your life, you know. And they were just saying, well, this is my charge load, my viral load, and my CD4 count. So that was their identity, actually. Okay. So users' views, okay? So you had this informal market going on with consequences for patients because patients were dying if they were selling their drugs. On the other side, people that were buying drugs, you know, it's drugs that need to be refrigerated, that needed to be taken every 2 hours with food, without food, with water, blah, blah, blah. And they needed to be really compliant to have an effectiveness in treatment. And then you had consequences in terms of public health, because if people were not taking their drugs correctly, you had a risk of disease resistance, okay? So that was a public health issue. So let's go back to what interests us today. What we've learned without consulting users. Well, we've learned that we doubled the numbers of therapies and we made therapy available. We've learned that the program was implemented but not as planned, and that there were different difficulties of implementation. But when you add the views of users, you see that, well, extensive consequences of social stigma, but there is the existence of a large informal market around antiretroviral drugs. So before users' views were incorporated, the evaluation targeted mainly program management issues. And incorporating users' views led to a complete reinterpretation of the program's impact in terms of effectiveness, an urgent need to do something in terms of public health, and a complete reconsideration of drug use best suited to needs. And major changing, I will breathe, I will take your advice. So, we integrated, what happened? Okay, there was this major AIDS conference and we decided to do a conference on informal market in Chile. And it was a period of elections, presidential election in Chile, so the media came, took the message, and it had a huge influence in the media, okay? The government decided to do things to stop this informal market, and what did they do? No more B therapy, just free therapy, just to have the best therapies available. They decided to improve drug management because there were, well, anyway. And they adopted a new law, and this is really important, a new law that extended the coverage to every person born in Chile living with HIV/AIDS and allowed the right to free care by the government. So even if you were insured by the private system, you were allowed to have your drugs free through the public system. And they decided to improve the coverage, and in 2003, the coverage was 90% of the needs, okay? So you've seen that this little research, it was not planned to go into informal markets, but it was, I decided to meet patients, okay? And by meeting patients, you slowly discover other things going on, and you are able to completely reinterpret your results. Okay, let's go on. Project 2. Services integration for people with co-occurring disorders and mental health and with co-occurring disorders of mental health and drug use, okay? You have people with both problems, mental health and drug use, which are huge users of the healthcare systems. They use emergency rooms and they go to psychiatric services, but they are told, you are a drug user, please don't come here, and you come back when you stop using drugs. They go to rehabilitation center and they are told, well, you have a mental health problem, go to psychiatric services and you will come back later, okay? And at the same time, you had new clinical guidelines that said, we are able now to have an effectiveness on patients with co-occurring disorders, but we have to integrate services, to merge services of mental health and rehabilitation in the same clinic. And they tried the experience in Montreal. I was in charge of the implementation analysis again. When I met, so I decided to meet professionals, managers of the clinic, okay? And I conducted also a logic analysis. And what came from the analysis of the theory of intervention is that if you want to integrate services, the key success thing will be to share the same norms of practice, which is called normative integration. And clinical protocols are a tool for developing this kind of integration, normative integration, because you go with your colleagues, you discuss, I do that with my patients, well, I don't do that, I don't accept that from them. The harm reduction approach with the, for example, on one side, I accept that from time to time they take drugs, but other professionals can say, well, it's not in my practice, you know, I won't tolerate any drug use while they are under treatment. So they have to discuss and they have to agree on one way to deal with these patients and offer treatment. So that was really important. And when I conducted the evaluation of the clinic, they came with built protocols, rich protocols, and they were implementing them, working with them, and everything seemed all right. And one thing that was really convergent in people's discourse was that the clinic was central in patients' trajectory. They said, we offer an integrated approach according to different protocols, and we are central. Once the patient is admitted in our services, we talk with their former professionals and we become central, we coordinate care. It is, if we can say, their house. They are welcome here, we treat them here, and we are completely central, and this is a component of the effectiveness of our treatment, of our intervention, right? So, after a few years, you know, I conducted these interviews, we made the analysis, and we arrived at the end of the project, and we had focus groups with patients that were planned at the beginning. And you know, with the end of the project, sometimes you become lazy. No, I shouldn't say that, okay. We experienced data saturation. We had the good view of the program. We understood, we had a profound understanding of the program. So I thought, do we really need to do these focus groups? Because everybody told us, oh, this will be, you know, they were with severe mental health problem and drug addiction, and there was those people where you can't do nothing in society with them, and they were rejected from every services, and you know, and people said, wow, you're really so courageous to organize this focus group. And I said, do we really need to? We had time, we had money, we said, okay, let's go, let's do it. We plan to do it, we do it, and we'll see what occurs with that. So we conducted focus groups with users. And what we've learned? Well, we've learned that they had a variety of difficulties of problems. Actually, we knew that before. We've learned that they use a variety of services from justice, housing, community meals, and et cetera, et cetera. Actually, we knew that, okay? We've learned that they were treated by different professionals who each had their own practice philosophy. And that was the beginning of an important thing, okay? Because, sorry. What happened is that you had, for example, you had people that were living in the street and they were offered housing in a program. But there was a philosophy around this program too, okay? And were they tolerant according to their drug consumption or not, okay? And in some housing system, they say, if I take you while taking drugs, you are fired, you will lose your apartment, you will lose your house, okay? So, you had, and these people, as they had different problems in life, problems with justice, some were in prison or in probationary liberty. They needed housing, they were in different resources, so they had to navigate with the various professionals' behaviors and expectations in order to protect themselves from losses in different spheres in their lives. And even if they have mental health problems and drug addiction problems, they are really intelligent and they know where are the greatest losses for them, okay? And they will deal with that, okay? They will say, the most important for me is to have a shelter tonight, okay? So I won't say I won't tell my doctor I am using drugs, you know, and I will conform to these housing expectations and keep my shelter. Right? So what happened is that you had a clinic that offered integrated services, and they said the centrality of the clinic is a determinant of our effectiveness. But when you meet patients, you realize that the clinic is not central in their life trajectory. Okay? There are various professionals and they will behave according to the different expectations to protect themselves. So they won't tell the truth to their doctors. Okay? And the clinic won't be central. So will it be effective? That was a big question. So, what we've learned without consulting users, well, that there was a good normative integration in the clinic, that the clinic, according to professionals, had a good centrality. But what we've learned from consulting users, that this centrality of the clinic did not exist in their health trajectory, and that there were several professionals outside the clinic with important levers. So the contribution of incorporating users' views, well, it helped us to revisit the integration challenge. The challenge was not only to offer an integrated approach that allies psychiatric and addiction rehabilitation practices, but also to develop a response that is consistent with those of other professionals outside that islet. And this is a whole other challenge. Therefore, service integration projects need to extend beyond psychiatric and addiction rehabilitation resources and be based on patients' life experience. Okay, third project. Improving the healthcare trajectory of people with hepatitis C. Okay, even if we have a universal healthcare system in Canada and in the various provinces, people with hepatitis C in Quebec, there were only 10% of people diagnosed in a 5-year period that received treatment for their hepatitis in Quebec. So even if there is a treatment that is available with an effectiveness of 50 to 80%, you have barriers to access to care. And people, if they are diagnosed with hepatitis, will unlikely won't receive care in most of the cases. And what explains that? Well, it can be explained by the prejudices of professionals, maybe, that's hypothesis, because most of people with hepatitis C are injection drug users, and they have various problems, and sometimes they have to be disorganized, and professionals are reluctant to welcome their clinic disorganized persons. So what was the aim of the evaluation that time? That time, the aim of the evaluation was to solve the problem of access to care for people living with hepatitis C in a region in Quebec. Okay, so we used a collaborative approach. We invited several stakeholders around the table. We invited 10 to 15 stakeholders gravitating around people at risk of getting hepatitis C, mainly drug users, people with hepatitis C, and people treated for hepatitis C. So you had representative of patients, you had associations for HIV/AIDS, you had associations for drug users, you had community resources, the community meal, you had primary care nurses, you had specialists, gastroenterologists, infectiologists. Okay, so you had a large table with large expertise around the table. And the idea in this project was really to discuss on the users' views and users' data, okay? So we used a deliberative approach where we offered some data to our stakeholders around the table. We showed that data, that analysis, and then we had shared time in our meeting for data presentation and then discussion. And the idea was to answer their questions, to open their mind, open their knowledge about the problematics, but also to get their expertise and their solutions for solving the problem, okay? So that was the idea of the project. So you see that the place given to users this time is a bit different as in other projects. What we've learned? Well, we've learned by consulting users that, well, it's changed completely. We learned lots of things, actually. We wrote a full article on their views, but I chose the elements that struck me the most, okay? Or struck, not me, but the stakeholders around the table the most. The first element was the need for needles. That was greatly underestimated, okay? You have a free distribution program in Quebec, okay? So you can go to different resources and ask for clean needles, and you will receive a kit, okay? But people will give 1 to 3 kits to people asking that clean needles, okay? And stakeholders knew that mostly in the region it was cocaine users, and that cocaine users inject more often. But they didn't realize that they needed hundreds of clean needles, okay? When people are in their injection period, they will inject 20 to 30 times. So it's hundreds of needles a week. So do you cover the needs when you just distribute 2 or 3 needles at a time? Not really, okay? So that was, they knew there were cocaine users. They knew there was a huge need of needles, but they didn't realize how big was that need, okay? The other thing was the injection practices in prison. You know that prisons are closed environments and that drugs are not allowed in prisons. But there is drug use in prison, okay? And the drug users we interviewed and people, we conducted three or four focus groups with injection drug users, with people diagnosed with hepatitis C but not receiving treatment, and people diagnosed and receiving treatment, okay? And we worked with their perceptions, and some of these people had been to prison, and they said, well, you know, in prison drugs circulates, but it circulates better than clean needles, actually. And there was a guy who was in a federal prison, and he said, we were several hundreds on the same needle, okay? So we know as a society, we know in prison, well, these people were in prison because they were using drugs, okay? And there are drugs circulating into prison, but how should we address this question? You know, because we have to address it. We can't close our eyes, okay? So that was an important question that was raised. And actually, we didn't find a solution or an answer with our stakeholders around the table. But they all agreed that was an important question, and they wanted to make a follow-up, you know, to see if they could contact people in prison and try to address this question. But the importance of health for injection drug users, that was another important message. When we interviewed these people, you know, they all said that when they were in their period of injection, they didn't expect to live long, okay? They were ready to die. They didn't fear death. It was just like that, you know, it was living in present. But at the same time, in their discourse, it was really important to be in good health. You know, they said, I wanted, you know, to be not to seem dirty, not to seem ill. I want to be in good shape. I want to be, you know, beautiful, okay? And the health message was important in their present time. And that was a really important message for prevention, because to take a concrete example, if you have primary care nurses, they will meet injection drug users, and they will have the disease trajectory in their head, and they may say, you know, you have to use clean needles to prevent yourself from getting AIDS, for preventing yourself from getting hepatitis C, because if you get hepatitis C, you will die of cancer in 20 years. Do they mind? They don't expect to live in 5 years, okay? So in 20 years, no matter. But at the same time, they're interested in their health, so they can say, let's see, how is your arm? Does it hurt? Do you have any infection? Can I help you to feel better in these days, okay? And to develop a trust relation, to begin a relation with this person, okay? To be heard, to develop a relationship, and then a few days or a few weeks later, you can talk of other health issues. And that was an important message, because health nurses didn't realize that health was so important, and they decided to change their practices and change their prevention message to reach better injection drug users. Last thing, the importance of support during treatment. That was really important too, and that was for people that decided to enter into treatment. Actually, this treatment is not easy, okay? It will hurt you, it will hurt. The people who had mental health may have a reactivation of mental health. You will suffer in your body, and people said that it was really hell being under this treatment. So people feared to enter into treatment. But what happened is that all the people, every person we met that was under treatment decided to go under treatment because of love. Okay, I don't want to tell you a love story today, but that was important, because they met their partner and they decided that they would be ready to live the next 20 years with this partner, and they wanted to clean their body, and this is the word they were using, okay? So they went to the doctor and they said, I met someone who is really important in my life, and I want to clean my body, so please do the test and I will do the treatment, okay? So they were doing the treatment, but the treatment was so hard that in the end it was threatening their love relationship, okay? Because they were with mental health problems. They were fighting with the disease, fighting with drugs. They were hurt, and they were not easy in their day-to-day life. So their partner was not recognizing the same person, and they were losing their love. That was the determinant of their treatment, the main determinant of their treatment. So that was really an important question, because we realized how it was important during the treatment period to offer psychological support to the person, but also to the partner, okay? And that was another important thing we realized. So in conclusion, 3 different evaluation projects. You see that the place given to users was different in each project. In the first 2, mainly it was interviews, but it offered a completely new reading of our results. And in the last project, the project was built to integrate, built around the views of users, okay? And incorporating users' views had a great influence on the reading of the program or the problem and the study. In Evaluation 1, the UNAIDS initiative, it offered a new reading of the effectiveness of the program, and it had huge impacts on policy. In Evaluation 2, the integrated services for people with co-occurring disorders, it allowed a new reading of effectiveness of the program, and it allowed us to redraw the boundaries of integration. And in Evaluation 3, care for people with hepatitis C, it offered new strategic perspective. It allowed us to identify where we should go forward to be effective in their health trajectories. It's clear that this new reading of results and evaluation is insufficient to have an impact on policy or on program improvement, but it is a necessary step to make changes, to introduce changes, and to propose improvement. And you see how important it is to have an acute and an exact reading of your program. So I would say it's a necessary step. And then the key message, well, as an evaluator, okay, even if you are confident to have a solid understanding of the program, and this is important because each time, you know, you conduct your interviews, you meet more people, and at a moment you say, well, I think I know well this program now. So even if you're confident, you have a solid understanding of the program, even if you experience data saturation, okay, because we experience data saturation with the professionals and administrators we met, it is always important to incorporate users' views. It might change completely the reading of your program, of your results, and it might have a huge impact on policies and on improvement of interventions. And you might be surprised of the impact it may have. So I thank you now.
Astrid, thank you for an incredible presentation. I mean, there are so many things that are to be, I think, admired in your presentation. It is not lost on us that you have chosen to speak to us in one of 2 official languages of this country. And I think it's just really commendable that you did such a fantastic job. And we do appreciate the fact that you
thank you.
are respectful of our relative lack of language skills, shall we say, in Canada's other official language. We are so lucky, fortunate, to have a person of your incredible skills and talent and passion to speak to these really important issues. I think the 3 examples you gave are terrific examples of real-world issues that people working in the sector that our colleagues will be working in need to be mindful of. And even if they're not evaluators, opportunities to say, hey, wait a minute, what about the voices of the people that we're trying to provide these services for? So I just want to do a quick check-in on time here. we're going to take a very brief health break in a few minutes, but we do have about 10 minutes for questions. So I'm going to play Phil Donahue, and for those of you who are not of my generation, that was a guy who walked around the studio audience and gave out a microphone to people who had questions. So, thank you, Helen. Sadly, that's true. Okay, so okay, so we got a couple of questions here.
Thank you, Astrid. That was. I'm super keen about the incorporation of the client voice into service planning, and so this was exciting to listen to. So thank you for sharing that, and certainly your positive perspective about the need of the population. What I'm interested in, so I'll keep my question tight, is your opinion and any experience with gendering the data. So looking at even with this particular population, especially about the differences in you're using the term users, but I would like to term the women's voices when you were looking at this particular project.
So the place of gender in these two projects, is that right?
Yeah, or in general, if you would choose to, whatever you feel like you'd like to comment on. I'm just interested in the gendering of this.
Actually, it was not something we put the emphasis on, okay, because we were considering users in general, and we didn't look for what was the special voice of women and experience of women. I think, I think one way of getting it is if you believe that women's experience is different in society and that their reading of the program may be different, it will be important to give an emphasis to this person and include that. The way you would include it will be the same, I think, as for others. You can think about different ways in your research. But, okay, maybe I will answer another way. The way voices are integrated into the projects may be really different. At that moment, I've talked in the introduction that it may be instrumental, but it can be also included into the approach. Okay, so the influence gender will have on your research project will depend on the place you want to give to gender, and it's clear that you can design your evaluation research by including gender into that and surrounding your design around the voices of women. And you can use on the other side women's voice as instrumental into your research project. So I would say here in these three projects, we didn't put the emphasis on gender. It's clear that experiences may have been different, but I think that the obstacles, the difficulties people were facing were so important that, it was the same challenges of access for all of them, even if they may have been differences of gender. But as a researcher, if you feel it's an important question, you can rethink your research design according to this question and give more voice to these persons.
Just before I pass on the microphone, part of the reason why we are using the microphone is, of course, we are web streaming as well. And I'll say hello to all those people out there in the world of the internet who have joined us. Welcome.
Thank you so much for your presentation, Astrid. I wanted to ask you a question about the first evaluation, the one that you did in Chile. And I'm very curious if you know the basis on which the policymakers made the decision to allow people who had AIDS to have free access or access to the medications that they needed. Was the argument that was presented to them primarily financial? That is, if we can reduce the transmission rate, which will end up costing us less. Was it moral, this is the right thing to do, or was it just one of those lucky flukes that happens every now and then? Or do you know?
the question of access and the decisions regarding access were really complicated and political in the country. Okay, actually, the provisioning of drugs was done according to a protocol that was decided in the health ministry. But when we met the professionals and the doctors that were prescribing, they were not practicing according to those protocols. So even if you had a lack of drugs for the people, you had cupboards full of acetate in English, full of drugs that were unused because they were not prescribed by doctors. So you had these differences, you know, between what the government was ordering and thinking was good practice and what professionals were thinking what was good practice. And so it was a really political question. Now on the impact of our evaluation on those measures that were taken by the government, I think it was not rational. It was a political decision, clearly. You know, in fact, for the little story, when we decided to submit this abstract to the health conference, we didn't think it would have such a huge impact. And we wrote the abstract, and you know, we said to the stakeholders, the health ministry, we will, you know, we will tell you if we try to publish our things. So we sent the abstract to the health ministry, and they said, you are not allowed to give this conference. How? How come we are not allowed? So they called the French agency of research who had different projects in Chile, and they said, if they present their conference to the AIDS conference, we will stop all your research project in the country. So the French AIDS agency just called and said, that's not so important, okay? Maybe you could do something else. And so we decided, no, that's important. And we worked finally with the health ministry, and we said, okay, we will write this conference, we will write the text, you will read the text, there will be no surprise, okay? So they agreed with this way of working, and it's true that journalists were there, medias were there, and it was in the newspaper, and it was in the newspaper because there was presidential election, and that was, you know, a cute subject to pop up in the media. And once it was in the media, the government had to do something. And the people from the health ministry working on the AIDS questions had goodwill, you know, they wanted to increase availability of drugs, but they had to work with close budgets. And in final, it may have helped them, you know, to have this burst in the media, because government had to engage into something to solve this solution.
So I see 3 other hands, and I see we have just about 2.5 minutes. So, all right, so we're gonna do the best we can here.
Okay, so first, good morning, everybody. Kathy Worthington, I'm a faculty member at the School of Public Health and Social Policy. That's my first question or request for everyone, because we're going to have teeny tiny heads on the TV screens, and the people at home would like to know who you are. I would love to finally put the little teeny tiny photos back into real people. So when you ask a question, could you say who you are first? Thank you. So my question for you, Astrid. I mean, thank you, this is wonderful. This is the stuff that I'm passionate about too. Because all of you have taken some program evaluation in your research methods courses, Astrid, could you say a little bit about the models that you drew upon? You've all heard of empowerment evaluation, you've all seen Bradley Cousins' model, you've all seen community-based research. Astrid, what models do you draw upon in your work?
That was a tiny question, right? Fortunately, I will have only tiny.
You just say all of them.
Well, the 2 first projects, the UNAIDS and the co-occurring disorders project, where I was doing an implementation analysis, and the way I conducted this implementation analysis were first to draw the logic model, to draw a conceptual model, and now I more and more work with doing first a logic analysis where I analyze the theory of the intervention, and then I conduct an implementation analysis, doing interviews, case studies most of the time. In the 3rd project, it was a bit different because we developed a research design based on empowerment evaluation, And it was not a true empowerment evaluation, it was an adaptation, but the idea was to gather stakeholders in a non-threatening manner and use their inputs to interpret objective data. And that was the idea, to present them objective, valid data and have a sound discussion on what it means for them and which solution we can bring forward. So what kind of evaluation is it? Is it an implementation analysis? Is it a strategic analysis? I've not made up my mind actually with that, because the process was more important than the type of question we were asking, which was not the case in the 2 other projects.
Well, listen, thank you, and I am sorry, but we are out of time. So, Astrid, I'm sure if you have questions, would happily answer them just offline, as it were. So this brings to an end our first session. We're going to have a short break now. Just one slight housekeeping, in fact, 2 slight housekeeping things. For those of you who are not familiar with this building, the washrooms are just to the, would be the left of the front doors as you're leaving. Through that door there. Secondly, there are other users in this building. So I would invite you, if you want to grab coffee or whatever, if you maybe want to have a chat outside. It's a beautiful day. We ordered up this weather especially for you. And so, because it's a bit of a cavern out there, as you probably have already heard, people talking, it fills the whole building. So we've just been asked to be mindful of the fact there are other sessions going on in the building. And we'll reconvene in 15 minutes. Thank you, Carmel.